I know Lee has talked about his experience at the West Clinic, but I'll just give you a little bit of our where we are now. So really, we actually went through the same issues with the biosimilar pegylated G-CSF, and we did a conversion. I mean, we still have problems with that, unfortunately, because, a lot of people come to the University of Pittsburgh where, again, we're a big academic center, but we have a large network that's now actually probably 60% of Pennsylvania in terms of area. We've gone all the way across almost to Harrisburg and up to almost to Scranton.
Interesting.
Yeah, so we have sites all over. And so we're trying to figure out, and the payer mix is a little bit different in the eastern part of the state than the western, but nonetheless, we have a large experience really with a conversion to both the biosimilar G-CSF and the biosimilar pegylated G-CSF. And the big issue with us with the biosimilar pegylated G-CSF, before we start talking about trastuzumab, the big issue was, you have the OncPro device, which is very easy to use.
Same day.
It's very easy to use. You can just put it on the patient, wait for the light to turn green 24 hours later, and you take it off. And the problem, though, is if you're going to give the biosimilar, I think it's Udenica.
We
use Udenica. There's other ones, but we decided on
Fulphila.
We decided on Udenica for a variety of reasons, and I can get into that in a minute. But the thing is that we use Udenica, but the issue with Udenica is that we have to have the patient get an injection a day later. We have to find somewhere, especially if someone comes to see me from 4 hours away. A lot of people want to stay and get their chemo with us, even though it's a long distance. And if you're getting a Q3-week regimen for breast cancer, or Q2 if you use dose-dense chemotherapy, you have to kind of figure out where the patient is going to get. Either they're going to give it themselves, or they're going to find someone to give it. And a lot of times the payers, they can't give it themselves. The payers require they have to be given in an oncology office. In an office. So it's a really interesting decision. So we went through this whole thing, and made all the decisions. And then we've decided on Udenica, but we still have we track our use, as I'm sure you do.
Oh, yeah.
And our use right now, and we actually have an oncology P&T committee that's comprised of pharmacists and oncologists representing all of our various constituencies. We have community oncologists, we have academic oncologists, we have, I think there's someone in the nurses, and we have pharmacists, both
so you have 340B as well? Or
we do, and that's the issue with us. We have 340B for a lot of our practice.
You are also OCM site
we
as
are
well.
OCM, our community practice, it's interesting.
Yeah.
Our community practice are OCM, but the academic ones are not. It's very complicated.
Very
complicated. We have two different EMRs. It's a real interesting kind of dilemma. But the bottom line is that, our oncology PT, in fact, we just met yesterday to discuss a lot of this. The way it works with us is that we have a lot of issues that go into it. Because a 340B issue with the drug is much different than the commercial issue.
Correct.
And much different than the payer mix. It's very, very complicated. I mean, I thought naively that it was simply, if they're all three the same price, or all five in the case of trastuzumab, if they're all the same, it's like, we'll just kind of pick the one that gives us the best, support, or the best company that we can be assured that there won't be a supply problem.
Correct.
We would assume that we would do all that, but it gets I didn't realize how complicated it really was. And it's interesting, we have this huge spreadsheet now that you have to put in all these variables for it to spit out what we think the best one is for us, and it gets very, very complicated. And so, it's not just, and again, it's going to be, we're a kind of a complicated system, but I think that there's just a lot of things that go into this, as you said, besides cost. And we decided that we know, for example, there's going to be a certain amount of OncPro use, the Amgen device. There's going to be a certain amount of that no matter what. And I think because there are patients that come from 4 hours, but someone who maybe doesn't come from 4 hours and basically can get it in either a doctor's office or an oncology office or themselves, the perfect is the enemy of the good. And I think if you can get up to maybe 70-80% conversion, I think that's fine.
Absolutely.
Chasing 100 is where you run into trouble. You spend all your time chasing that extra 20% for no reason.
And you are absolutely right, Adam. I think in the end of the day, we all became doctors to help patients. So when you have a patient who has to drive 4 hours, if I use 20% Onpro, my contract may not be best, I may actually lose money, but I still would use it because I did not want to look at finance as the bottom line for what I do.
Right.
At the same time, if I have an option of using in 80% of the patients, I definitely would be happily using. But I'm really happy to see that, we all are thinking alike, that end of the day, we do not want someone to drive 4 hours to come to the clinic and
just to save a certain amount of money, right?
And
it's interesting if you have a company that actually has biologics, has generics plus
Mm-hmm.
plus the originator.
It does help.
You know, and maybe they're two different classes. You know, maybe what you can do is you can cut a deal. You know, where you still do get, you know, even though you're using 20% Onpro, maybe you're using other biosimilars from the same organization, and you can cut a whole big contract that everybody's happy. I mean, this is the complexities, and so the issue is that that's how we're still trying to decide. There are 5, as you know, different trastuzumab biosimilars now, and it's a very, very complicated decision, but it's made by a P&T committee. We have a P&T committee that meets, an oncology P&T committee. It's kind of a subcommittee of the larger P&T of the health system, and you know, we meet, and again, it has comprised of the various stakeholders, and we sit and we talk, and you know, the thing is, it's a very complicated decision. That's why it's taken us so long to make that decision, because there's so many variables that go into it.